Hi, I'm Dr. James Amos. I'm a consulting psychiatrist at University of Iowa Hospitals and Clinics in Iowa City, and this is another in the series of Dirty Dozens on psychosomatic medicine, and this one is about psychosocial assessments for transplant psychiatry. And if you're seeing this on YouTube, you're welcome to go to my website, The Practical Psychosomaticist, at jajsamos.wordpress.com to see the full presentation with slides and annotations. I'm going to follow some slides here that I have in front of me so that I stay on track, and we'll have time only for a brief overview of this process, and I'll confine myself to adult transplant psychiatry. First off is historical overview, and that's slide 3. It sort of covers a broad spectrum of time from 1933, in which the first human kidney transplant was performed, all the way up to 1978, when cyclosporin, an immunosuppressive agent, was first introduced. And it marked passing from an experimental procedure to the standard of care in transplant surgery. And in the 1980s, the United Network of Organ Sharing, or UNOS, started administering the Organ Procurement and Transplantation Network, or OPTN. And it facilitates organ matching and data collection about transplants in the U.S. And I included a link to the OPTN website. Slide 4 has to do with talking about organ transplant as an emotional experience, and it's an emotional experience not just for the patient, but for transplant center teams, which consists of a wide variety of stakeholders, including surgeons, other med-surg specialists, the transplant coordinator, and many others. We often think of organs as and the organ transplant as being the gift of life, but implied questions often come up that might strike the patient as being sort of confrontive or provocative, such as, hey, why do you need a new organ? Do you deserve it? How bad do you want it? And what will you do in order to preserve the graft? Those are questions that are legitimate, and depending on how they are delivered, will make the patient a central figure that who feels supported throughout this very challenging process. Slide 5 is about candidate selection, which is made necessary by the scarcity of cadaver organs, and the number of persons needing transplant far exceeds the number of available organs. And each year, unfortunately, 10 to 15% of liver, heart, and lung transplant candidates will die while on the wait list. And a shocking figure is that about 18 people a day die waiting for organs on the wait list. Graft survival rates also happen to be lower than patient survival rates, so many will need more than one transplant. So the implications for transplant centers and patients is that there's a need to craft selection criteria to find optimal candidates, and this drives the trend to try to find living-related donors and altruistic donors. Psychosocial evaluations are now considered to be an essential part of the selection process, and greater than 95% of transplant programs now require some kind of psychosocial evaluation, whether they're done by psychiatrists or transplant social workers or other mental health care providers. Slide 6 is about an important issue involving how we view the psychiatrist in the transplant evaluation process, and whether we view the psychiatrist as a gatekeeper or a collaborator. And thankfully we're moving beyond the stage where we view the psychiatrist as a gatekeeper, and we've evolved much beyond that. Challenges with viewing the psychiatrist or psychosocial evaluator as a gatekeeper are that it tends to perpetuate a paternalistic care model. It also focuses the role of rationing, or tends to focus the role of rationing, on one member of the transplant team. And there's a difficult balancing act between identifying mental illness and helping the transplant team resist the tendency to stereotype that mental illness. There's also difficulty in being identified as one who can detect impression management by the potential transplant candidate, which may involve normal putting one's best foot forward in the pre-transplant evaluation process to actively hiding stigmatized problems such as mental illness and substance abuse, which there are resources for treatment. Viewing the psychiatrist as a collaborator rather, and as an interdisciplinary team member has many advantages. There are many members on the team, as I've already alluded to, and as we work together as a team, we can focus on identifying psychosocial challenges to address in order to maximize post-transplant chances of a successful outcome for the potential transplant candidate. Slide 7 is a little bit more on the psychiatrist as collaborator. The psychiatrist as collaborator has a duty to several stakeholders, and that's to the transplant candidate, other patients on the wait list, living related donors if they are viable alternatives to cadaver organ transplantation, to society in terms of husbanding the scarce resource of cadaver organs, and also to the transplant service, which in order to sustain an acceptable accreditation status must also sustain an acceptable survival rate of patients. It's also important to point out that with regard to the Americans with Disabilities Act, psychosocial assessments regarding this prohibit discrimination on the basis of eligibility criteria that may disproportionately affect Americans with disabilities. Denials of organs should be based on scientifically valid criteria to the extent that they're available, and transplant programs should make reasonable steps to compensate for any disability. Slide 8 has to do with preoperative psychosocial evaluations. The goals are to assess the psychosocial function of the candidate and his or her support group. It's also to assess mental status and decisional capacity. The third goal is to ascertain the candidate's suitability, and that entails trying to evaluate several characteristics of the patient and the patient's support group. It's also important to diagnose psychiatric disorders that may interfere with suitability, and also to identify resources for enhancing suitability. Common contraindications from a psychiatric standpoint to suitability to suitable candidates would be active psychosis, active substance abuse, a history of noncompliance with medical recommendations, and some transplant programs involving certain organs tend to be stricter, such as for heart transplant, and others tend to be a little more lenient, such as kidney transplant, because of the availability of alternatives such as dialysis. Slide 9 is about the data supporting psychosocial evaluations and their usefulness, and I'll touch on a couple of rating scales or decision support tools that we use. Some preoperative psychiatric syndromes persist and worsen postoperatively, and we need to be aware of that so that we can provide greater support to the patient. Delirium is a very common problem in up to 70% of patients who have chronic organ failure, and they're at higher risk for delirium postoperatively, and we need to be on the alert for that. Mood and anxiety disorders that can be exacerbated by common immunosuppressive agents like corticosteroids are an issue that we need to be aware of and be ready to address when and if they occur. Personality disorder, as it arises, tends to cause or lead to worse outcomes in terms of survival and morbidity, mainly because of noncompliance with medical recommendations. Psychiatric disorders, though, per se, in terms of their impact on survival and morbidity, it's really not clear that psychiatric disorders by themselves lead to worse outcomes per se. And this comes from the reference from Rosenberger and others. One example of a decision support tool is the psychosocial assessment of candidates for transplantation, which has been around since the late 1980s. It focuses on specific psychosocial issues relevant to transplant rather than psychiatric diagnoses per se. And it was developed by Walpurch and Levinson at Virginia Commonwealth University, and it's copyrighted, so you should obtain permission from the developers before you use it. Another newer decision support tool is called the Stanford Integrated Psychosocial Assessment for Transplantation, or the SIPAT, and this was developed by Dr. Jose Maldonado and colleagues at Stanford. And it has developed psychosocial listing criteria that perform at least comparably to the PACT, according to the authors. It has excellent integrator reliability. It's standardized, and it identifies patients who might be at risk for negative outcomes post-transplant. It's a definite step forward in the evaluation of potential transplant candidates, and you can go to the Stanford Psychosomatic Medicine website to view that. And once again, you should request permission to use the scale from Dr. Jose Maldonado and colleagues. In terms of the issue of living unrelated kidney donors, specifically altruistic donors, this is an important issue, and living unrelated donors may be sought on the internet, and there's really no way to monitor or regulate this kind of activity. It's illegal to buy and sell organs, but it's really very difficult to regulate how donors and recipients get together who are not related, and to make sure that altruistic donors have the safest possible pre-transplant medical and psychosocial evaluation so as to maximize outcomes for both the donor and the recipient. Lower risk or protective factors for donors in situations like this would be no recent losses or stressors, realistic expectations about the donation experience, and a perception of the recipient outcome that is realistic as well. Higher risk factors that may not bode well for donors in situations like this would be unrealistic expectations, a motive for recognition or publicity, a relationship with the recipient, and specifically one which may be subordinate, and also multiple stressors. There is a very nice blog post on my website by Dr. Stephen Potts in the United Kingdom about this issue, and I'd encourage you to read that, and that'll be in the list of references and resources. And the last slide, of course, is the list of references and resources for psychosocial assessments for organ transplant. And it's a very brief overview. It's really an introduction, and I hope you enjoyed it. And if you have any comments or questions, please visit my website, The Practical Psychosomaticist, and have a good day.